and also patient safety. And one of the big roles of the future will be trying to find out how we go about assessing the new service that we've brought in. This can't be done at the moment because it's not a fully established service, but I'm sure it will come over the coming months and years. So what have been identified as the potential benefits to the advanced critical care practitioners? Well, there's very few hospitals that have the practitioners up and running in a fully in full capacity. But there's been a number of benefits that have been hypothesised with the introduction of it. And the first is timely care. With practitioner-led clinical interventions, we allow minimising the delays in the treatment and also reduce the waiting times for procedures. We allow the appropriate investigations and the initiations of treatment to be done quickly, and there's expertise and experience available at the point of care, really meaning that the help is there as soon as the patient needs it. A lot of the literature surrounding recognition, assessment and management of the critically ill patient, such as the early goal-directed therapies and the surviving sepsis guidelines, have highlighted the importance of early recognition and treatment of severe illness and the reductions in mortality that can result from early intervention. We also provide effective and safe care by providing a critical care service without walls. It's not currently within our scope to routinely assess severely ill patients who present to A&E or who are deteriorating in the ward, but what it does do is it allows us to provide the cover and support to allow the senior medical staff to safely go out of the unit and to review the patients and provide the expertise and the quality input that they need into their care. We also like to think that we have a better compliance with the care bundles that are used to reduce the hospital-acquired infections and other mortality and morbidities, and to the implementation of and keeping to the protocols and guidelines that are there to help us. This is really in contrast to a continually rotating medical group at the level that we practice. We're just at the stage that they're getting used to the protocols and the pathways of care that we use. They're then moving on to another area, and there's another new group coming in. Through the pattern-based recognition processes and the experience that we've got, we hope that this is going to impact on the care that the patients received. We'd hope that our expertise will reduce the admissions into intensive care and the readmission rates into intensive care, possibly through a follow-up service, and also a reduction in the readmissions to the high dependency units. We would hope that it would provide a reduced length of stay for patients through continuing the patient progression and expertise in subjects such as weaning from mechanical ventilation and other specialist interventions. There's also a reduced risk to patients, having a group of practitioners that have well-developed practical skills. A lot of these interventions from a practical point of view have risk attached to them, and obviously you want people doing them that are well experienced and have done a good number of the procedures to reduce the incidence of any complications. We also play a role in enhancing the training for junior doctors and the multidisciplinary team, and I think that's something that's often forgotten. It's really a level of support that was previously unavailable to the junior doctors and to the rest of the team, and it seems to be, from the feedback that we get from the nurses, it's a very open and approachable service that we deliver from the education point of view. I mentioned earlier that we have improved compliance with the working time directives, and hopefully all this will result in improved patient experiences. There's also plus points with staff retention and career progression. By improving the career opportunities for the nurses and the other allied healthcare professions that take upon this role, we hope that really we are able to keep these people in the unit and in the clinical area as an alternative to the traditional role of going down the charge nurse route. Like I say, one of the upcoming challenges that we have ahead of us is to try and audit and find out how effective the service is that we deliver. And I think this is important for groups like ACAP that can provide a network to see how other people are managing to do this, really, and how they are managing to achieve and what markers they are using to help them with their auditing. And I think by sharing these ideas and the initiatives that we've had in the area will make it a lot easier by reducing the need really to reinvent the wheel. It's not all been plain sailing though. There has been a number of challenges that we've encountered whilst introducing the role. The first few, in fact all of them with the exception of the integration of rota, raised their head fairly early. And the first one that I'd like to talk about was the attaining of competencies. As part of the first, in fact of all of the modules, but particularly the first one, we were very much relying on the acute medicine registrars to help us with the competencies that we had to attain for patient history taking and clinical assessment. And this was mostly done out in the acute medical wards, like I say, to try and give us exposure to the patients that we needed to be exposed to. But there was also a lot of competition from other medical staff and other practitioners who really wanted to get their competencies signed off as well in order to be deemed competent. And there was also some issues with the engagement from the medical registrars whose workload all of a sudden jumped up quite significantly. And some of them really were quite sceptical about the roles of advanced practice and didn't really want to have any responsibility for deeming us competent. And it really took quite an immense amount of persistence and resilience on behalf of all the practitioners to get the competencies done, and it took up a fair bit of consultant time as well. The university modules that we undertook, with the exception of the work-based modules, were fairly generic. They weren't really all adapted to the acute care setting, especially with respect to the prescribing modules, and it had at times almost no or very little clinical relevance to what we were going to be doing when we go out there into the big bad world. And this was really tackled by CPD days that were introduced to try and ensure that we had a sufficient knowledge base and ongoing competence. And these were run as parallel study days that were arranged by the clinical education team, and they covered a lot of the pharmacology that was needed specific to intensive and high dependency patients, and also the specialist groups of drugs that we were going to be using. There was a certain amount of uncertainty with regards role clarity. There was a lot of confusion as to what actually we were going to do, especially within the training phase. The practitioners really had to embark on an ongoing PR exercise, really to try and highlight what our role is and to engage with the people on the ward that were asking what it was. And that didn't just involve the staff within our directorate. We had to do this beyond our directorate as well, as we were involved in referrals and accepting patients and handovers, for example, patients coming back from theatre. We also had practitioners that were in different phases of their training and with different experiences and backgrounds, and people often found this quite confusing. In order to get over this, we had arranged several workshops and sessions to allow discussion of the changes and hopefully to help people bring in ideas that could make the role a bit better really, and to try and help engage everyone in the changes that were going ahead. I'll come back to the integration of the rotas and go on to another issue that we had fairly early on, and that was the acceptance of the role itself. I think there had been quite a comparison made to the physician's assistants that I had spoke about earlier, especially from the anaesthetic personnel. And they had had some difficulties in the past with the bedding in of this service, but really there's an important point to note, and that is that there's some significant differences between the two roles. All of the practitioners in critical care had extensive experience as senior nurses within the area. I think the average was about 10 years experience, and most of them were at kind of junior or senior charge nurse level. we're also able to prescribe drugs, which is something that the physician's assistants weren't able to do, and most importantly we were able to work independently. And I think this took quite a while for some of the medical staff to grasp. There was also difficulties generally towards us taking on the role of prescribing, as it was really quite a whole new concept to critical care. And like I've alluded to earlier, the specialist nature of some of the drugs and the treatments made people quite nervous about this. Again, we addressed this through the use of the continuing professional development programme and involving the specialists in initiating the service, such as the clinical pharmacists, and making sure that they were on board with us. One of the more recent problems that we've had as we have finished our training and become fully established in the role is the integration of the medical rotas. The maths of it seems fairly straightforward, and I don't really think any of us kind of envisaged it being a problem at all, but it's been probably one of the most challenging aspects of introducing the role, and it is a little bit like kind of trying to get apples and pears to fit together. I think really the basis of this is the historical differences, both in the rota patterns, the shift times, and also the cross-site coverage and the rotation as well makes it a bit of an issue. This hasn't really been fully settled at the moment. It's an ongoing process, and it really probably won't get sorted out until the second cohort complete their training in August. But hopefully it will be something that we can work through fairly effectively and get it working for the better of everyone. Overall though, I think recently people have been very accepting of the role. It seems to have been very successful, and that's really across the board from both the medical and the nursing and the other healthcare professionals, and really at all levels as well, from the junior nurses right through to the consultants. And it actually gets to the stage now that they're actually quite pleased to have us on duty with them. So what does the future hold for us? Well, it's very different across different trusts, really dependent on the service needs. And I think to bring the service forward and to develop it, there's got to be one kind of underpinning principle, and that is really that the service should only be tailored to the needs. I think that's important because it allows you to direct your learning. If you go on and learn new skills and you don't have the opportunities to use these skills, then you can't possibly maintain the competency surrounding them, which really makes it pointless in the first place. So before you take on these roles, I think it's very important to make sure that it's something, before you invest the time in taking on the role and all the education that it entails, that there really is a need for you to be taking on certain aspects. With respect to advanced airway and central venous access, at the moment it's not a necessary role in NHS Lothian, but it is taken on by some practitioners throughout the UK. Some of the practitioners in England and through in the West Coast and up north do advanced airway management and central vascular access. I'm sure it's something that will come in time as there's less senior medical staff around, with the shifts in the medical education, and it's something that we may need to look at in the future. With these skill set, it will also allow us to take